skin and soft tissue infections and UTI. So skin and soft tissue infections, SSTIs, involves any layer, epidermis, dermis, subcutaneous fat, fascia, or muscle. It can be mild and self-limiting to severe, progressing to complicated infections, septic arthritis, osteomyelitis, bacteremia, endocarditis, etc. Empiric treatment based on severity and site of infection, patient underlying disease, and probable etiology. Factors that predispose to skin and soft tissue infection. High concentrations of bacteria, so greater than 10 to the fifth power. Excessive moisture, such as obesity, inadequate blood supply, availability of bacterial nutrients, damage to corneal layer allowing bacterial penetration. Definition: acute inflammation and infection of skin and subcutaneous fat, cellulitis, which includes erysipelas, manifests as an area of skin, erythema, edema, and warmth. It develops as a result of bacterial entry via breaches in the skin barrier. Predisposing factors: venous or lymphatic insufficiency, diabetes mellitus, or other immunosuppressive states, alcoholism, obesity, breaks in the skin trauma, pre-existing skin infection. Skin barrier disruption due to trauma such as abrasions, penetrating wound, pressure ulcer, venous leg ulcer, insect bite, injection of drug use. Skin inflammation such as eczema, radiation therapy, edema due to impaired lymphatic drainage, edema due to venous insufficiency, obesity, immunosuppression such as diabetes or HIV infection, breaks in the skin between the toes, so toe web, intertrigo. These may be clinically inapparent. Pre-existing skin infections such as tinea pedis, impetigo, and varicella. Signs and symptoms are erythema, edema, warm to touch, diffuse tenderness, indistinct borders, ledinopathy. Common bacterial causes in otherwise healthy people, think skin flora, penetrating compromised skin unless otherwise infectious source. Teeth: Streptococcus mutans, bactericides, Fusobacterium, streptococci, actinomyces. Mouth: Streptococci, trichomonas, candida. Throat: Streptococci, Neisseria, staph, hemophilus. Skin: staph, diphtheroids, strep, pseudomonas, candida, pityrosporum. Intestine: Bilobacter, Bacteroides fragilis, Eubobacterium, Enterococcus, E. coli. Urethra and vagina: staph, diphtheroids, strep, gram-negative rods. Groin, perineum, and skin. Lungs: pneumocystis carinii. Uncomplicated cellulitis, so a previously healthy person. Pathogens: Group A, Streptococcus, gas. Hemolytic strep, primarily S. pyogenes. S. aureus, which is MSSA, or S. aureus MRSA. CA MRSA causes serious infection in otherwise healthy persons who have not been recently hospitalized. Transmission of MRSA, complicated or uncomplicated disease associated with minor skin trauma, sharing of sports or personal care equipment, sharing of close quarters, recent hospitalization or surgery, and others. No obvious risk factors, but associated with dermatological conditions, diabetes, and smoking. Note, treatment variation where CA-MRSA is suspect. Haemophilus influenzae, children. Complicated cellulitis, immunocompromised DM, vascular insufficient, use of injectable drugs, etc. Pathogens, MSSA, HA, MRSA, CA, MRSA, Enterobacterococci, P. aeruginosa, and anaerobes. Predisposing factors above increase risk of polymicrobial disease. Empiric antimicrobial therapy for cellulitis. So previously healthy, the probable etiologic bacteria, so MSSA, gas, or MRSA would be dicloxacillin, cephalexin, clindamycin, trimopterin, doxycycline, linezolid. If they have a moderate, so that was for oral. For IV would be nafcillin, cefzolin, clindamycin, vancomycin, linezolid, daptomycin, ceftaroline, vancomycin. Oh wait, I'm going to a new one. Okay, so immunocompromised, so diabetes, vascular insufficiency, peptic ulcer infection, or other polymicrobial infection suspected, so MSSA, MRSA, Enterobacterase, Pseudomonas, anaerobes. So PO is amoxicillin, clavulate, so augmentin, levofloxacin, clindamycin, maxfloxacin. And then IV would be vancomycin or linezolid, piperacillin, ampicillin, iradapine, maripin, cefepime, cefazime, or ceftraline, clindamycin, metronidazole. Do not memorize doses. Patient-specific factors, allergies, drug-to-drug disease interactions, pregnancy, children, etc. Recall examples. Avoid penicillins or cephalosporins in patients with a history of hypersensitivity. Type 1 to these classes of medications. DI with quinolones and mono and divalent cations, calcium, mag, etc., iron. Avoid cyclines, doxycycline, tetracycline, and quinolones in children. Altered renal, hepatic, biliary functions. Side note, penicillin, cephalosporins, carbapenems, allergy. History of penicillin reaction, not always reliable, as 5 to 8% claim to have a history, but only small number have allergic reaction. Hypersensitivity reaction occur when penicillin is degraded to penicillic acid and other compounds that combine with proteins in the body to form antigens, which cause antibody formation. If hypersensitive, use alternative antibiotic. Skin testing can be done. Cross-reactivity between penicillins and cephalosporins or carbapenems 3 to 7% use alternative antibiotic in the case of prior anaphylaxis. Erysipelas, more superficial infection with very sharp raised border, systemic symptoms. Necrotizing fasciitis, deep subcutaneous infection that causes necrosis of the fascia and subcutaneous fat with rapidly progressive inflammation. Treatment of necrotizing infection consists of early and aggressive surgical exploration and debridement of necrotic tissue together with broad-spectrum empiric antibiotic therapy and hemodynamic support. Animal bites. Most animal bites are caused by dogs, cats, and humans. The predominant organism in animal bite wounds are the oral flora of the biting animal, as well as human skin flora, such as staph and strep. Pasteurella multicida prophylaxis. Prophylactic antibiotics reduce the rate of infection due to some animal bites, especially cat bites. So, agent of choice, amoxicillin debullante, or alternate empiric regimens include one of the following agents with activity against multicida. So doxycycline, TMP, SMX, penicillin, cefuroximide, moxifloxacin, plus one of the following agents, metronidazole or clindamycin. Treatment of documented infection versus prophylaxis, same as above, but for 10 to 28 days. Rabies and tetanus prophylaxis. Impetigo, seen mostly in children, highly communicable, especially in hot, humid weather. S. pyogenes, B. hemolytic strep, S. aureus. Treatment may resolve on its own with no pharmacological interventions. Anti-staphylococcal penicillins such as dicloxacillin. First generation cephalosporin, so cephalexin. MRSA is suspect or penicillin allergy, then clindamycin with SMZ/TMP or doxy. Note, tetracyclines, including doxycycline, should be avoided in children. Topical muriprocin or bacitracin for non-bulbulous impetigo. Please do not spend a lot of time on erysipelas, necrotizing fasciitis, or pressure sores in terms of the exam. Urinary tract infections. Presence of microorganisms in the urinary tract that cannot be accounted for by contamination. Elderly. In older adults who are cognitively intact, the diagnosis of symptomatic UTI is relatively straightforward. In older adults who suffer from significant cognitive defects, impairing their ability to communicate, and chronic genitourinary symptoms, e.g. incontinence, urgency, and frequency, which make the diagnosis of symptomatic UTI in this group particularly challenging. Furthermore, when infected, nursing home residents are more likely to present with nonspecific symptoms such as anorexia, confusion, and a decline in functional status. Fever may be absent or diminished in the setting of atypical symptoms. Providers are often faced with the challenge of differentiating a symptomatic UTI from other infections or medical conditions. Symptoms of frequency, dysuria, hesitancy, incontinence may not be diagnostic of UTI in the elderly. Additional diagnostic information for all patients and when symptomology is unreliable. urinalysis, greater than 105 traditional definition. Nitrate reduction tests. Nitrate is formed by bacteria that reduce nitrate normally found in the urine, signifies the presence of bacteria. Leukocyte esterase, significant presence of WBCs found in primary neutrophil granules, sensitive and specific for 10 WBCs. Hematuria, microscopic or gross, nonspecific but commonly seen in infection. Color, turbidity, specific gravity, and other. Children. Children with UTIs manifest different symptoms depending on age. Uncomplicated UTIs refer to infections in healthy premenopausal adult females. Complicated UTIs refer to all other types of infections that are not considered uncomplicated. Causative organisms, uncomplicated. E. coli is the most common, 80 to 90%. Staphylococcus, Klebsiella pneumoniae, Proteus mirabilis, Pseudomonas, Enterococcus. Repeat culture if S. epidermis is identified. Initially considered as a concomitant, frequently isolated from the urinary tract. Pyridium or phenazopyridine. Urinary analgesic, non-prescription, and no antimicrobial activity. The dose is 200 milligrams 3 times daily for a maximum of 2 days. Administration, take with a full glass of water, take after meals to minimize upset stomach. Contraindications are liver impairment and renal insufficiency. Side effects: headaches, dizziness, stomach cramps. Urine discoloration, red or orange, may stain contact lenses, fabrics, and clothes. Warnings or precautions: acute renal failure, hemolytic anemia in patients with G6PD dependency, may mask symptoms of an untreated or inappropriately treated UTI. Cranberry products. No evidence to support its use as treatment for UTI. Use is focused on preventative strategy. The dose would be 300 to 400 milligram tablets twice daily, 8 ounces 3 times a day of unsweetened juice. Side effects: drug interactions and GI effects. Cranberry juice. Antibacterial activity of the urine is related to low pH. Large volumes of cranberry juice is thought to interfere with bacterial adherence mechanisms. Acidification of urine by cranberry juice does not appear to play a significant role in the treatment or prevention. Benefits appear minimal, and larger studies with oral tablets or capsules are needed to support efficacy. Antibiotic selection. Selection of pharmacologic therapy based on site of infection, severity, and signs and symptoms. Whether infection is uncomplicated or complicated. Other considerations are cost, side effects, antibiotic susceptibility, current antimicrobial exposure. Uncomplicated cystitis, usually treated empirically with a urinalysis. If there is an inadequate response with empiric antibiotics, then check urine cultures. Pharmacologic therapy, uncomplicated UTI. Nitrofurantoin, 100 milligrams twice daily for 5 days. Fosfomycin, 3 grams single dose. TMP SMX, I think that's Bactrim, right? 160/800 milligrams twice daily times 3 days. Pivamicillin, not available in the US. Those are first line. Second line would be B-lactams, such as amoxicillin, clavulante, so that would be like Augmentin, cefdinir, ceflicor, cefoxidine, 3 to 7 days. Fluoroquinolone, so Cipro or levofloxacin for 3 days. Uncomplicated pyelonephritis. Severity of infection determines setting of treatment. Perform the following at time of presentation: urinalysis, urine culture, sensitivity test, gram stain of urine. Treat empirically, then adjust therapy once results come back that identify the pathogen. Mild to moderate is outpatient treatment for pyelonephritis, and that would be fluoroquinolone, so Cipro 500 twice daily for 7 days, levofloxacin 750 times 5 days. Avoid if resistance is greater than 10%. TMP SMX 160/800 milligrams twice daily times 14 days, or amoxicillin clavulante, so Augmentin 875/125, 3 times daily for 10 to 14 days. Avoid if resistance is greater than 20%, or if TMP SMX was used for UTI in the past 3 months. Complicated cystitis. Fluoroquinolones, so Cipro or levofloxacin, so Cipro is twice daily, 7 to 10 days. Levo is 5 to 7 days, once daily. Avoid if resistance is greater than 10%. TMP-SMX, again, that's like Bactrim DS, whatever. It's a sulfa drug. Or amoxicillin clavulante, so I'm just going to say Augmentin from here on out. So the Bactrim would be twice daily, 7 to 10 days. Amoxicillin 3 times a day, 7 to 10 days. Avoid if resistance is greater than 20%. Complicated pyelo, mild to moderate. Fluoroquinolone, so Cipro 500 twice daily, 7 to 14 days, or levofloxacin 750 daily, 5 to 7 days. Avoid if resistance is greater than 10%. Bactrim 160/800 twice daily times 14 days, and Augmentin would be twice daily, 10 to 14 days. Avoid again if resistance is greater than 20%, or the Bactrim was used for UTI in the past 3 months. UTI in males. Consider complicated because infection typically occurs in the presence of functional and or structural abnormalities that disrupt normal defense mechanisms. Obtain a urine culture because pathogens are not as predictable compared to infections in women. Important to have follow-up cultures at 4 to 6 weeks after treatment to ensure bacteriologic cure. UTI in males is either Cipro, levofloxacin, or the TMP SMX, so trimethoprim sulfamethoxazole, which is the Bactrim, and it's 7 to 14 days. UTI in pregnancy. Pregnant women should be screened for bacteremia by urine culture in the first trimester and treated if positive. Asymptomatic bacteremia is only treated in pregnancy and in patients who are unable to communicate symptoms. Some antibiotics are safe through the entire pregnancy, some only during specific trimesters, and some not at all. It is our responsibility to know this information and prescribe responsibly. UTI in pregnancy. Treat for approximately 7 days, so amoxicillin, Augmentin, cephalexin, Bactrim, ceftriaxone, fosfomycin, that's for cystitis only, and nitrofurantoin, cystitis only. Avoid the following due to risk of fetal harm, so tetracyclines, fluoroquinolones, and nitrofurantoin in the third trimester, and then the Bactrim in the third trimester. Prostatitis. Inflammation of the prostate gland and surrounding tissue as a result of infection. Prostatitis treatment is either Cipro, levofloxacin, or the TMP-SMX, which is the trimethoprim sulfamethoxazole, or Bactrim. So it's 4 to 6 weeks for acute, 12 weeks for chronic. Final notes. Asymptomatic bacteremia is treated with antibiotic tailored to the susceptibility pattern of the isolated organism, which is generally available at the time of diagnosis. Potential options include beta-lactams, nitrofurantoin, and fosfomycin. The choice of antimicrobial agent should also take into account safety during pregnancy, including the particular stage of pregnancy. It is extremely important to know the duration of treatment for complicated versus uncomplicated infection.